A 42-year-old male presented with recurrent febrile urinary tract infection with difficulty in voiding, diagnosed with recurrent episodes of acute prostatitis. He's received at least 3 courses of 3 to 4 weeks of antibiotics suitable, and this MRI shows prostate is not enlarged. However, it is infiltrated with the dirty material, showing as a hypointense in MRI. So it was planned for a radical TURP, failing all the conservative treatment. So you can see this prostate is not enlarged. He doesn't have a bladder outer obstruction. So the indication is all the glands which have inspissated secretions, we have to de-roof them. So you have to be radical in this, reach the capsule, but at the same time, one has to be careful and slow. Take small bite each time so that you don't perforate the capsule too early, and don't want to preclude the procedure without maximal drainage. You see these cheesy or inspissated secretions which harbor bacteria and leads to recurrent infections, because we know in prostate most of the antibiotics cannot penetrate in good concentrations. The notable groups which can actually penetrate are fluoroquinolones, trimethoprim, and lately fosfomycin. So in this gentleman, based on culture, everything was tried, but it failed. You can see this when the glands are being de-roofed, that small area pockets of cheesy material is, I shouldn't be saying cheesy because it is typically used for tubercular. So this whatever dirty material is being extruded. So we'll have to go all around. Now this patient was desperate because of recurrent febrile infections. We did inform him that this procedure can lead to very high chances of dry ejaculation and an occasional incidence of worsening of erectile function. But he was agreeing to it. He had his family complete and had a stable partner, that is his wife. And after proper counseling, he agreed to the procedure. You can see that I'm taking very small bites. I have no hesitation in taking small bites and facing that I'm making some sort of hesitation cuts, because this is a special situation. Prostate is not a large one, and I have to make sure that slowly I reach the capsule in one piece so that I don't have to stop the procedure too early. In between, I will keep on checking, coming back to the verum montana, so that I don't injure the external sphincter zone. I'm using Olympus bipolar, which gives a very nice thin slice, even if I have to do a very micro cut, which is, in my experience, I might be wrong. Karl Stoss is not able to give this fine kind of chip resection. Now the same things I'm doing on the right side. You can see the fibrotic tissue in the bladder neck and these inspissated secretions, corpora myelitia, on microscopic level we call them. It is being excised. You can see the capsule near the bladder neck, and on this side, so you can see when my resection is starting, I'm taking intermittent bites so that I don't go suddenly too deep. On the right side, there is nice thinning of the capsule. And see, even if I coming to very close to the sphincter, the glands are there which are inspissated, but we have to stop at the sphincter zone, so I wouldn't go beyond the verumentanum. Now this is a small prostate, so I don't have much tissue anyway beyond verumentanum. But you see, I'm going deeper using very thin slices. Even then, the inspissated material is there. I will have to de-roof all this. So one strategy may be in a location where we can't go too deep. So one can use cautery bipolar energy and hope that it will penetrate deep, and by heat it will kill the bacteria. Now, obviously, there is no high level of evidence for this, but it makes logical sense, and we practice it in once in a while when we get such a case. Now, not surprisingly, sometimes in desperate situations, radical prostatectomy has been performed for these kind of situations which have recurred even after a radical TUR. Now, I have been fortunate that I haven't encountered such a case where, after having done a radical kind of TUR, the recurrent UTI situation has recurred. Unless there is uncontrolled diabetes, or at times the patients are on SGLT2 inhibitors like dapagliflozin and they have a lot of glycosuria, so they may present sometime with recurrent UTI. But in this was a non-diabetic man, so this was not a concern in this case. So typically, most of the dirty glands, in my experience, we found from mid prostate to near the apex, the verumontanum area, not near the bladder neck, because at the bladder neck you have those muscular fibers, and you will see again and again in between. I am coming back to the verumontanum, checking for sphincter all around, and having my lines clear for the limit of dissection. These are the slight capsular perforation where I had encountered a small sinus. That was not a problem. On the right side, it's particularly uh, dirty, and see this small area of perforation into the dermal fascia. It was shocking for a while, but I put my finger in the rectum and checked for integrity of the rectum and perirectal tissues. So it was okay. But for a moment, when it was so deep, it gave a momentary anxiety of whether I was in the rectum or not. Coming back to the left side again, you might be thinking, why am I showing such a small prostate TUR when you have such beautiful videos available for large prostate TURs and all that. My only aim of this video is to show that for patients with recurrent urinary tract infection, prostate is one source which at times is forgotten. We tend to give antibiotic and keep on giving antibiotic on empirical basis. So this is a situation where one has to think out of the box. You rule out other sources of infection and get an MRI done. And if you have this and the patient is desperate, one can go for TUR. You have to choose your patients well, and in a well selected group, this strategy works well. You do have to tell your patient that in these kind of situation, there might be chances of stricture of bladder neck or urethral stricture because it's an inflammatory disease for which you are doing this procedure. Fortunately, in this patient didn't have, but we do encounter sometimes. And once the patient is counseled preoperatively, they will tend to accept well. So I'm doing the resection all around, Usually in a TUR, I will leave the 12 o'clock strip of mucosa, uh, which potentially reduces the risk of bladder neck stenosis. In this case, because I want to de-rough all the dirty glands, I'm not leaving anything around. You can see even on this side, near the prostatic apex, you see these glands being de-roofed, and I'm not hesitating in making fine slices. Olympus is giving me an edge in enabling me to take such fine slices. If you've come this far, so it's obvious that you're keenly interested in managing this small and frustrated group of patients. And I hope, guys, this video will help you in doing an adequate TUR in these desperate cases. There's a button electrode which helps in nice hemostasis, and also it can cause nice ablation of small areas which are left behind, like this. You can see. So this is the ablation I'm doing, and that's it.